Okay, good evening, everyone. I would like to welcome you all for a quite interesting symposium on male hypogonadism. First of all, I would like to thank the Gulf Association of Endocrinology and Diabetes for organizing this meeting. I would like also to thank our guest speakers for being with us tonight and for you being late to attend such a interesting webinar. Thanks also to Amber exhibition organizers, specifically for Rafat Hosni for the technical assistance and organizing the meeting. A few housekeeping notes. The topic will focus on male hypogonadism. The diagnosis and pitfall in diagnosis will be addressed by our guest, Professor Richard Quinton, and then the management will be addressed by Dr. Shehzad Basaria. The CME certification, it's a CME accredited event offered by the Dubai Health Authority. The certificate, you will be received the certificate 4 to 5 weeks from today. There will be an evaluation form. We would appreciate your feedback. Probably this will be a way to guarantee that you have took some time to put your feedback on the event. And with this, I have the great honor to introduce the first speaker. The first speaker will be addressing pitfall in the diagnosis of male hypogonadism. It will be addressed by Professor Richard Quinton. Professor Quinton is a consultant endocrinologist, Newcastle upon Tyne hospitals, and senior lecturer, Translational and Clinical Research Institute and Newcastle University. He's a receiver of many awards and has many publications in the field of hypogonadism. He is he's actually examiner of the European Board exam in endocrinology, diabetes, and metabolism. And he has contributed, as well as Dr. Shehzad, I think, for the Society of Endocrinology guidelines on male hypogonadism. I think it was published in Clinical Endocrinology recently, 2022. And with this, I think he's really the most qualified person to address the topic, pitfalls and the diagnosis of male hypogonadism.
So a huge thanks for the invitation and for that very kind and generous introduction. So many thanks again for this invitation, and it's a privilege to interact with you, and also to have Dr. Ali Khalil and Professor Shehzad Basaria here as part of the panel. So you know what? Here are two wonderful statements. I can't quite remember who said what and when, but I think it was between Bradley Anawal, Shalenda Bassett, and Professor Basaria. So male hypogonadism is misdiagnosed, overdiagnosed, and undiagnosed in equal measure. And also, in many cases, those men receiving testosterone treatment are not the ones who are most likely to derive the greatest benefit. So the topics I'm going to cover, first of all, to discuss how in the UK Society of Endocrinology we've defined male hypogonadism. Talk a little bit about the homeostatic regulation of the male hypothalamo-pituitary gonadal axis. Go on to the laboratory diagnosis of hypogonadism and the diagnostic subclassification. To review presentations of hypogonadism across the male lifespan. And I understand we've got some gynecologists here and general physicians, as well as endocrinologists. Would it be nice to have some pediatricians? And we'll see why that later on, because I really am going to go across the entire male lifespan. Missed neonatal and adolescent diagnosis, which is of relevance to our pediatric colleagues. And then what we're more familiar with, the kind of false positive diagnosis of central hypogonadism due to things like non-standard venipuncture conditions, obesity, or non-gonadal illness, And finally, misdiagnosis of primary hypogonadism in old age. Our colleagues in elderly care medicine assume that anemia is a function of old age, and in some cases it is. In other cases, it's simply because they haven't actually screened or diagnosed hypogonadism, which becomes increasingly common as men get older. And then finally some concluding thoughts and take-home messages. This is the science bit. I promise you, this is the last bit. And I just really want to emphasize the components of the male pituitary gonadal axis. So here, adipose tissue. Well, we need enough of that. Not too much, but not too little. So if you don't have enough adipose tissue, you don't make enough of the hormone leptin, and therefore your arcuate nucleus in the candy neurons in the arcuate nucleus switch off. They stop making kisspeptin neurokinin B, and your generation neurons in hypothalamus switch off, and then everything switches off. We see this more commonly in females with anorexia or hypothalamic amenorrhea, but actually we increasingly see it in men who just exercise so much that they've got virtually no fat mass, they're all muscle, and actually their hormone axis shuts down. And last summer I had a call actually from my local Premier League football club, which incidentally actually is Saudi owned now, about one of their players whose libido had just collapsed. And of course, he was the man with the highest aerobic fitness and lowest fat mass in the entire squad. Answer, feed him up, give him some more food. But also too much fat. So too much fat contributes to chronic disease. I can call sleep apnea, and any form of chronic disease can shut down the male axis. So downstream, you can think of the generation neurons and the pituitary gonadal as being like the slaves. They kind of do as they're told. The testes are interesting because they show both endocrine and paracrine effects. So we're aware of the endocrine thing. So LH stimulates the Leydig cells to make testosterone, and they go out into the and that goes out in the circulation. But actually, levels of testosterone in the circulation, in the testes, are far, far higher than they are actually outside the testes. And these very high paracrine concentrations of testosterone are what you need in conjunction with the other Leydig cell products, interleukin factor 3 and FSH, to act on Sertoli cells to guide the germ cells to become mature sperm. In terms of the negative feedback, some of it's directly on the pituitary gland through testosterone or dihydrotestosterone, but probably quite a bit of it actually is more central at the hypothalamus, and that's mediated by metabolism to estradiol, and so it's blocked by SERMs and AIs. So if you or I or other males took tamoxifen or clomiphene or anastrozole or letrozole, it would bump our LH and FSH and testosterone levels up the scale. Wouldn't improve our libido particularly, because actually libido, interestingly, is quite estrogen dependent. So how does the Society for Endocrinology define male hypogonadism? So first of all, we don't like testosterone deficiency. We think this is a descriptive term rather than a diagnostic category. So we say it's a clinical syndrome comprising clinical features and laboratory evidence of impaired testosterone secretion and potentially reduced fertility. We're not saying you should get a sperm count in everybody. What we would say is, if your sperm count's normal or fertility is preserved, you're very likely to be hypogonadal. However, having said all that, primary hypogonadism with like raised LH can be reliably diagnosed on a single venipuncture, and without actually any clinical correlation, because it's so utterly obvious. And although the diagnosis of hypogonadism conventionally requires 3 sexual symptoms to be present, in fact, testosterone is equally important for general health as well as sexual and reproductive health. So if you're faced with an older man with primary gonadal failure, with anemia, osteoporosis, who really doesn't really care about sex anymore, then really the fact he doesn't have sexual symptoms shouldn't prevent you from making the diagnosis of hypogonadism and or treating him with testosterone. So laboratory diagnosis. For the last 20 years, we kind of worshipped at the altar of tandem mass spectrometry. However, although it's definitely superior to immunoassays in the female range, in fact, some immunoassays outperform mass spec methods in the male range. And actually, the between laboratory agreement for some immunoassays can be as good as 4% coefficient of variation. whereas for mass spec units, that can go up to plus or minus 10%. So mass spec is by no means the gold standard that was previously supposed, and a good immunoassay is not to be discarded, certainly in the male range. What's perhaps more important is your sampling conditions. We've always known that there was a diurnal variation testosterone levels with highest levels in the morning on waking and lowest levels in the evening. But actually, there's also an acute effect related to food intake, whether it's sugar or protein or a combination. And interesting, all these three key studies were all published in the UK journal Clinical Endocrinology. Why weren't they published in JCM? Answer, because in that period, JCM was worshipping in the altar of tandem mass spec and so wouldn't look at them. So anyway, we're lucky to have this UK journal. But essentially, whether you have type 2 diabetes, impaired glucose tolerance, or normal glucose tolerance, if you do a glucose tolerance test, you get a 20% drop in both total and free testosterone levels. And that can drop about a third of men into the hypogonadal range. So important, if you are going to measure levels, not just 9 AM, but also overnight fasted, just to try and improve your signal to noise ratio. A good night's sleep is also good, and not during periods of intercurrent illness, because any illness, not-gonadal illness, will tend to shut down your axis physiologically. It's what happens when we're ill. So the diagnosis is supported by a raised LH level, low bone density, anemia, or serum testosterone below reference range on at least 2 separate occasions. If your LH is up and you've got primary gonadal failure, we don't really see the point of repeating the sample a few weeks later. The diagnosis is made. However, when LH is not raised, and so you're suspecting central male hypogonadism, you need to do further investigations. Initially, pituitary function tests, particularly prolactin, iron studies, and usually MRI scanning, unless you think there's a really compelling evidence for non-gonadal illness. So this man has low LH, low testosterone, because he's got uncontrolled heart failure or morbid obesity. So in this situation, you wouldn't necessarily want to do the MRI scan, or need to do the MRI scan. What about free testosterone? So this is useful when your total testosterone is borderline or not consistent with the clinical context. So you measure an SHBG level, which allows you to do calculation of free testosterone according to the Vermeulen calculation. When your SHBG is mid-range, doing the free testosterone adds no value. Just stick with the total. But the free correlates better with androgenicity, with testosterone action in those who are SHBG outliers, high levels or low levels. One problem about the calculation, though, is the variability of analytic method used in routine clinical laboratories. So in the UK, we got 7 assays for testosterone, 6 for SHBG, each with their reference range. So 40 different permutations of calculated testosterone and of its reference range. And plus also the CV for SHBG assays is much higher. There's a lot more variation between labs for SHBG than there is for testosterone. So free testosterone, nice idea, useful in certain circumstances. But to be honest, if your SHBG is mid-range, don't bother. Stick with the total testosterone. When we talk about laboratory diagnosis, we tend to focus on biochemistry, but actually we forget one of the really important, readily available routine blood tests, which is the full blood count. This is Lance Armstrong. He knew all about the full blood count because he was abusing industrial amounts of testosterone. It was driving his red blood cell count too high. So in order to try and fool the World Anti-Doping Agency, he was regularly venesecting himself, donating blood. So interestingly, we're not entirely sure why testosterone drives your red cell count higher. The male count's about 20% higher than that of women or children, or of hypogonadal males. Could be direct stimulation of bone marrow heme synthesis, stimulation of renal and non-renal EPO secretion, erythropoietin, enhanced sensitivity of erythroprogenitors to EPO, so making you more sensitive to EPO. And the last kid in the block is inhibition of hepatic hepcidin secretion. So hepcidin secreted by the liver, and it inhibits intestinal iron absorption, or all of the above. But anyhow, it's a recognized phenomenon. So if anemia is present or not present, that gives you a clue as to whether hypogonadism is present. Also, we often see men who are diagnosed with hypogonadism, but when I can't see accurately classified, I do wonder about the credibility of the diagnosis. And really, through contextual, clinical, and lab ascertainment, diagnosis should be framed in relation to one of the recognized clinical causes, and whether the defect is testicular, primary, or central, secondary. If a man is said to be hypogonadal or having testosterone deficiency, and there's no other qualifier, I have concerns about the quality of the original diagnosis and would generally want to revisit it. So the clinical features of hypogonadism, just to emphasize that these can be reproductive or non-reproductive. The reproductive ones are sexual dysfunction, infertility, gynecomastia, and if it's very severe, failure or loss of secondary sexual characteristics. The non-reproductive ones fall into the physical and psychological. The physical ones, fatigue, reduced strength and endurance, anemia, osteoporosis or fracture, vasomotor symptoms. The psychological ones, interestingly, there is the weakest evidence of benefit with testosterone treatment, loss of motivation and concentration, apathy, irritability, low or labile mood. I'm not saying that these aren't associated with hypogonadism. I'm saying that when you treat with testosterone, these are the ones for which there's least evidence that they actually improve. And of course, for men with congenital hypogonadism, there's some really bad psychological issues like body shame, depression, and very severe psychological distress, often related to delayed diagnosis. So classification, primary, there's intrinsic dysfunction in the testis. The light bulb is broken. Secondary, it's a lack of LH and FSH stimulation. Nothing wrong with the light bulb, the light switch is turned off. And sometimes I actually do demonstrate that to my patients in clinic by occasionally plunging us into darkness and saying, no, you see, there's nothing wrong with the light, I just turn the switch off. Nothing wrong with your testes, it's not being stimulated from the pituitary enough. Primary, very easy to diagnose. Your raised gonadotropin levels make the diagnosis unequivocal under almost any sampling conditions. Secondary, trickier. Your LH and FSH levels are low or inappropriately normal, and this is biochemically indistinguishable from non-gonadal illness or an afternoon or non-fasted venofactor effect. So this is where your clinical context is vital to making an accurate diagnosis. I started to talk to you, I mean, the assumption is that hypogonadism, the adverts is always some middle-aged guy, isn't it, like me? But in fact, the presentations vary hugely across the male lifespan, from pediatric to geriatric. So neonatally, you may present with 46XY DSD, disorder of sex differentiation, ambiguous genitalia, or if it's less severe, bilateral cryptorchidism with or without micropenis. Childhood, delayed, absent, arrested puberty, gynecomastia, sexual dysfunction, infertility in adult life, vasomotor sweating and flushing, loss of sexual characteristics, and premature osteoporosis, anemia, and myopathy. So really, particularly any man with osteoporosis should always be investigated for presence of hypogonadism rather than just being dumped on a bisphosphonate, particularly if there's anemia as well. And I find that anemia and osteoporosis, the combination, that's a wallpaper match. You know, you have hypogonadism until proven otherwise, whether you have sexual symptoms or not. And this is another way of looking at hypogonadism across the age, even prenatally, in fact. So this is a schematic showing the activation of the male reproductive axis in life. And we start off in the fetus, and around 7 weeks gestation, HCG drives testosterone secretion from the testes. And this is what drives male external sexual differentiation. But if that's missing, you will be born either DSD or, frankly, externally female. Then around 2 months before birth, the fetal GnRH pulse generator starts kicking in, and that continues to around 6 months postpartum. And this is known as mini puberty. I'll talk about mini puberty later. Mini puberty is why when you change your son's nappies in the morning, they may have a little morning stiffy, a little morning erection. Not just because they're pleased to see you. And if that's missing, as in kind of Kalman syndrome, they may well be born with microphallus or cryptorchidism. Then, of course, the axis quietens down during childhood, and it picks up during puberty, either early, normal, or late. But if it doesn't pick up, then you present as an adolescent with absent secondary sex characteristics, unical proportions, gynecomastia, small testes, or an older age, low libido, low bone mass, muscle mass, low energy levels, anemia, or infertility. So one of my Kalman patients presented after 3 years of marriage. He's a very educated man, taught ancient languages at school, and he married for 3 years, pubertal. And I asked him, so what does your wife do? Oh, she's a primary care physician, but they taught her nothing about that at medical school. There you go. So I said I'd talk to you about mini puberty. So this is a surge in generation LH and FH secretion that creates the hormonal milieu necessary for the final testicular descent into the scrotum. And this involves both the Leydig cell hormones, testosterone, insulin factor 3, and also the stellate cell hormones, AMH and inhibin B, stimulated by FSH. And these help to re-anchor the testes into the scrotum, and also prime the testes for their future role as reproductive organs. Little boys may have morning erections. They don't make sperm, thank goodness. And this is because Sertoli cells until 5 years of age don't express the testosterone receptor. So luckily that's why little boys don't make sperm, because there's no paracrine testosterone action within the testes. So one of the things that really torments pediatricians a lot is how to distinguish patients with true hypogonadism from those with constitutional delayed puberty, or those who just got delayed puberty and nobody knows why, what they call delayed puberty query cause. But actually there's some really good red flag markers that'll tell you this adolescent, do not observe them, treat them. This adolescent almost certainly has got congenital hypogonadism because they've got a red flag. Don't just follow them a bit longer. Treat them now, age 12, 13, 14. So the red flags are present in about 60–70% of the cases of congenital hypogonadism, including Kalman syndrome. And these comprise historic indicators of absent mini puberty and the non-reproductive phenotypes associated with congenital hypog. So things like microphallus, much more prevalent than in the UK population. Cryptorchidism, bilateral cryptorchidism, absent erections on morning nappy change. And the non-reproductive phenotypes would be anosmia, deafness, cleft lip or palate, syndactyly, clondactyly, digital anomalies, or of course, having a family history of congenital hypog, so you're a child who's been born from sperm induction treatment. And our estimate is that probably about 5% of boys with bilateral cryptorchidism at 3 months will turn out to have congenital hypog, maybe more if they also have micropenis. And actually, you can diagnose hypogonadism in male infants by doing a simple blood test, LH, FSH, and testosterone, as long as you do it before 4 months of age, ideally at 4 weeks of age. Brilliant, 93% sensitive and 100% specific test. It doesn't get done. Kids with cryptorchidism continue to be sent to pediatric surgeons to be operated on without a diagnosis being made. You think, you make a diagnosis then, you can say, Mum, Dad, come back at 12 years of age, we'll need to induce puberty. Instead of waiting until they're 17, 18, 19, 20, and nothing's happening. And more importantly, if you give FSH and HCG to these kids, you can induce the testes to descend, so they don't need surgical orchidopexy. And you may even benefit their future sperm production capacity. So this is Neil's story. He's kind of like the world kind of Kalman syndrome's supreme patient expert. And so age 1 year, he underwent bilateral orchidopexy. Age 8 years, his parents' reality was anosmic. Age 14 to 17 years, consulted doctors 4 times, lacking puberty, always brushed off and told he was just a late bloomer. Eventually got to see a specialist, nearly age 18 years, received a homeopathic dose of testosterone for 6 months. Some virilization achieved and testes had grown. And so it was assumed that actually endogenous puberty had started erroneously, and he was discharged from follow-up. He was socially isolated. He underachieved academically at university and came back around age 25 years with arrested early puberty, congenital hypog, low LH, low FSH, low testosterone. And it's taken him like nearly 20 years to navigate this and find himself in life. It's been a bitter pill for him, being fobbed off for all those years. We talked about chronic illness, and any kind of illness, doesn't matter what it is, whether it's obesity or uncontrolled diabetes or heart failure or burns, your axis shuts down, and that's a normal thing. That can be indistinguishable biochemistry from central hypogonadism. But the important thing is that when you treat the underlying condition or it remits, then the gonadal axis fully recovers. And that's, so we know that with obesity, the weight loss restores gonadal chemistry, whether you do it through diet or whether you do it through a bariatric surgery. So this is often the night we see so many men in our clinic, the obese man with low testosterone. And we have to think, well, why might he have low testosterone? Well, first of all, he's got the same chance to be hypogonadal as a slim man. Second, it could be artifact. It could be an afternoon or non-fasted sample. It could be an insulin resistance artifact. So if he's hyperinsulinic, obese, insulin will tend to switch off SHBG secretion. So although his total testosterone may be low, his SHBG will be even lower. So the free testosterone may come out as being normal. And of course, it might be a low testosterone because of just being generally so ill with his obesity. And this is a normal physiological response, but we don't know whether it's adaptive, maladaptive, or neutral. And when you get the referral in, what's your first instinct? So mine is, I look up the hemoglobin in hematocrit. If he's got a high normal hemoglobin in hematocrit, which often you see in these insulin-resistant obese men, first of all, he's very likely to be hypogonadal. And more importantly, if you start him on testosterone, you'll very likely cause polycythemia or erythrocytosis, which is not good for your cardiovascular risks. In relation to aging, the European male aging studies showed that the overwhelming component to the decline in serum testosterone predominantly reflects the accumulation of non-gonadal comorbidities as you get older. But actually, a very small percentage of older men have low testosterone and have a high LH. They've got primary hypogonadism. And that may be a small percentage of older men. When you think about all the older men that there are out there, that's an awful lot of men there who might be out there with anemia that's been ascribed to chronic disease or to old age. This is from the Chinese equivalent of VMAS. This is the SPEC China study. And this is divided into cohorts. So these are the eugonadal men, normal LH, normal testosterone. His primary hypogonadism, 1.5%, just like EMAS, low testosterone, high LH. Here are the men with said to be secondary hypogonadism, but actually a lot of that low LH, low testosterone, but some of that could well be non-gonadal illness rather than genuine secondary hypogonadism. And up here, compensated hypogonadism. So this is normal testosterone, but high LH. So of course, you have to think, this is a biochemical construct. If you've got anemia, osteoporosis, azoospermia, or you can't get an erection even with Viagra, the question is just how compensated is that? But on the other hand, you might just have picked up an LH pulse peak. The LH might just have been like you caught a blip. Interestingly, in primary gonadal failure, so testicular dysfunction, the relative risk of having type 2 diabetes is trebled compared to background population. And that applies to both the age-related patients, but also to those with dystrophy mytonica or with Klinefelter syndrome. So there's something about having primary gonadal failure that trebles, associated with the trebling of risk of type 2 diabetes. So really, there is an andropause after all, but it's very rare. And the testes of more than 90% of older men retain the normal capacity to respond to LH and for the LH and for the ladies to secrete testosterone into old age. And actually, in the SPEC China study, the fall in testosterone levels with aging carried on until middle age, but the older Chinese men stick thin. They haven't adopted Western diets, healthy, exercise, tough as old boots. They retain the testosterone levels largely of younger Chinese men, apart from the small percentage with gonadal failure. So I'll give you some more patient histories. Now, this is Homer's story. That's not his real name, but I couldn't show you my real patient's name. So age 35, he noticed reduced libido and had some blood tests done. Tested 15 mil, he was well virilized, he was slightly obese. Testosterone slightly low, LH and FSH normal. Hemoglobin and hematocrit normal. He was started on testosterone gel and his libido initially improved. About 5 years later, he was referred for secondary infertility. And I was asked, well, would I treat him with a tamoxifen or clomiphene or anastrozole or even HCG? Testes were 10 to 12 mil, and he was oligospermic. My plan was, well, let's just stop the testosterone and reassess you in 3 to 4 months. And here we see that really he has a normal gonadal axis, and his sperm count is picking up. Libido is slightly worse, but with Viagra, he gets sufficient erections. So age 41 years, my wife is now pregnant. Can I restart testosterone? I say, well, I wouldn't recommend it, because really, if you've got normal fertility, that is not really compatible with a diagnosis of hypogonadism. I'm not prepared to restart it myself, but you can talk to your primary care physician about that. So now to Dave's story. In his mid-20s, he took steroids as an adjunct to weight training. He stopped 9 months ago, as his wife was now seeking fertility. Testes were 10 mil. He was azoospermic. He had suppressed gonadotrophins, low testosterone, and a very low SHBG level. Muscular guy. Low normal hemoglobin and hematocrit. So what are the possibilities for Dave? So could he have non-reversible central hypogonadism, and he needs a aromatase inhibitor, SERM, or HCG to try and wake his axis up? Could he be little Pinocchio? Maybe he's still taking non-testosterone androgens and just not telling his wife. Or maybe he really did stop androgens, but like much more recently than he said to us. Or finally, he really did stop androgens, but actually continues to use protein shakes, which actually are widely spiked with undeclared anabolics. So we can read the riot act in with his wife present. The wife's also always a very useful collaborator in this. 8 months later, he rang to say his wife was pregnant and did not return to clinic. I don't think he ever forgave me for embarrassing him in front of his wife. So, and then finally, this is really coming to my last vignette, and this reminds you why we're interested in adding quality years to life, not just years to life. So, age 64, he lost morning erections. His wife wasn't sad, so he told nobody about it. Age 66, he was found to have a mild normocytic anemia. Nothing was found in investigation, and this was said to be age-related. Age 69, he sustained an acute T10 vertebral fracture. DEXA scores was below. He had osteoporosis. He was started on standard treatment, calcium, vitamin D, and alendronic acid, 70 milligrams weekly. So what are you thinking? I hope you're thinking anemia, osteoporosis, hypogonadism until proven otherwise. And we can see, yes, that here he is. He's got low testosterone. Sorry, that's about 100 in American units in old money. And his gonadotrophins are raised. So he's got primary gonadal failure, which will give him a threefold risk of type 2 diabetes. We don't know whether testosterone treatment will reduce that risk. And it's associated equally with chronic aging and with comorbidities. Started testosterone. The question is whether to also stop the alendronic acid. And that's a difficult one. Part of me says, look, alendronic acid, you've got 5 years. Let's save it for later. When he's older, he'll get a great anabolic effect of testosterone on his bones. Part of me says, you know what? He's already had a T10 fracture. He needs to have a bone-specific agent. I don't know the answer to this, and I think this is where you need to have a discussion with the patient. Alendronic acid now or alendronic acid later. Certainly, he needs the testosterone. So these are my final slides and the take-home messages. Primary hypogonadism with a high LH is simple to diagnose in nearly all conditions or in all situations. But the diagnosis of central hypogonadism or secondary is only secure when framed in the context of a recognized clinical syndrome, so due to opiate use or pituitary tumor or pituitary surgery. Interestingly, though, you can diagnose central hypogonadism simply and very reliably, or you can exclude it, in boys with micropenis or cryptorchidism if you do the blood tests within 4 months of birth, preferably 4 weeks after birth, but nobody does it. Any man with a high normal hemoglobin and hematocrit, preserved fertility, or normal sperm count is very unlikely to be hypogonadal. And then, irrespective of sexual symptoms, the combination of normocytic anemia and osteoporosis or fracture in a man strongly signposts the presence of hypogonadism. So many thanks for your attention. Just to highlight a few papers of interest. This is my colleague, Dr. Al-Sharafi, originally from Baghdad Medical School, just showing how you can pick up so many men with primary gonadal failure just looking at acute medical inpatients with anemia. And he did a further review with Professor Jai at Imperial, looking at the overall androgens and anemia. Here are the guidelines from the Society of Endocrinology on the treatment of male hypogonadism. And finally, some reviews on pubertal induction in children, boys and girls, or even older with hypogonadism. So our record holder for induction of puberty in congenital hypogonadism is a man with Kalman syndrome, age 70 years old, who started his libido testosterone injections just before Christmas. So many thanks.
Thank you very much, Professor Richard. Really quite practical and relevant presentation. Now it's my great pleasure now to introduce the second speaker of tonight. Professor Shehzad Basaria is well known to a lot of us, actually, because he was with us in different meetings previously. And I hope Professor Richard will also follow his path in the future. He will be talking about management of male hypogonadism, following on the initial introductory presentation. Professor Shehzad is Professor of Medicine at the Harvard Medical School. He's Associate Professor, Director and Section on Men's Health, Aging and Metabolism at the Brigham and Women's Hospital. He has done a lot of work on testosterone, and he contributed quite a bit on our understanding of the effect of androgen deprivation, essentially from the cardiometabolic point of view, and on the role of testosterone replacement in patients with opioid-induced androgen deficiency. It also was part of the Endocrine Society guidelines for male hypogonadism, and I'm sure, as usual, he will guide us through the proper management of male hypogonadism. Professor Shehzad, the floor is yours.
It's a pleasure to be with you. I want to thank the Gulf Association of Endocrinology and Diabetes for their kind invitation, in particular Dr. Khalid Al-Damani and the rest of his organizing committee. Also want to acknowledge Amber Group for their support, in particular Mr. Arfat Hosni. And finally, thanking Dr. Khalil for the kind introduction, and also finally have a chance to meet Dr. Quinton. And above all the attendees. It's quite late in the Gulf, so it's a pleasure to speak to you, and I hope next time it'll be in person. So the topic of my talk is management of male hypogonadism, because the workup and how to diagnose male hypogonadism has been very eloquently said by Dr. Quinton. I do not have any disclosures. All our research funding is from federal agencies. So I have divided the talk into three broad elements. First, giving you a flavor and overview of various formulations of testosterone that are available. I know that they may not all be available in Gulf and other parts of the world, but at least I will introduce some of them to you and emphasize a little bit more on the existing traditional treatment that we have had for decades. then a brief section on potential benefits of testosterone therapy. And in the end, talk about some adverse effects of treatment with testosterone, some controversial, some very well known, just to give you a flavor. And at the end, during the discussion section, I'll be happy to take questions that you might have in this regard. Prior to discussing various formulations that are available, I would like to discuss some of the contraindications to testosterone therapy. Now, these are derived from the US Endocrine Society guidelines, and guidelines do vary across various geographic locations and organizations. So whatever guidelines you follow, I think this is something for you to decide how you want to enroll patients either in your research or start treating patients in your clinic based on the guidelines that you observe. Again, guidelines provide a roadmap. They are not gospels. Each and every step that you have to take is based on a patient-to-patient basis. So metastatic prostate cancer is considered an absolute contraindication, and so is breast cancer, because these two are steroid-responsive cancers. Prostate nodule or induration on your initial exam prior to starting testosterone therapy. Now, once you find such an abnormality, it is prudent to refer these patients to urology. And once they evaluate and think that there is nothing sinister ongoing, then you could initiate testosterone therapy once that has been cleared by urology. The guidelines also recommend that Caucasian men who have PSA more than 4 nanograms per ml, or African American men or men who have first order relatives with history of prostate cancer, if their baseline PSA is above 3, again, it would be prudent to get urology evaluation. Once that is complete and there is nothing sinister found, then you may initiate testosterone therapy. This does not mean that a person has cancer. This simply means that evaluation is needed at that time prior to initiation of testosterone therapy. Patients who have severe prostate symptoms, men who might have elevated hematocrit to start with, and Endocrine Society guidelines suggest that if hematocrit is greater than 48%, in folks who live at lower altitude or sea level, and greater than 50 for those men who live at high altitude. And the only reason these elements are incorporated in the guidelines is because testosterone improves hemoglobin and hematocrit, as Dr. Quinton mentioned. So if you already have an underlying condition that is keeping your hematocrit at the upper limit of normal, you are likely to have an increment of hematocrit in an abnormal range. And the whole process is to figure out, is there something ongoing even to start with, such as a hypoxic condition, sleep apnea or COPD, before initiating testosterone treatment in these folks. Men who have uncontrolled congestive heart failure, who have dyspnea at rest, and the reason being testosterone results in salt and water retention. So if you are already decompensated, it will further decompensate you. Once you are treated and you are properly controlled, then there is no reason why one should not initiate testosterone therapy. And lastly, if you have immediate desire for fertility, because testosterone therapy does suppress spermatogenesis. So I will take you through various formulations of testosterone that are available. And this provides you a snapshot that we have come a long way since testosterone was discovered, and the first formulation was used, which were testosterone pellets. After that, of course, we had short-acting testosterone esters such as enanthate and cypionate that were available. And as you know, injectables, either pellets or these esters, have been available for more than 8 decades. Oral testosterone undecanoate has been available in Europe and Australia for quite some time, but did not get approved in the United States. And then in 1990s started the era of patches and gels. Initially, it was the scrotal patch, which fell out of favor quite early. And then non-scrotal patch, which is still available, and I will talk about that. And then in early 2000s, gels were discovered, and various formulations of gels are available in Europe, Australia, and United States, which are in use. Nowadays, there are new formulations of testosterone undecanoate pills, which are approved by the FDA to be used in men with hypogonadism. And then in early 2000s, mainly in Australia and Europe, testosterone undecanoate injections, ultra long acting injections were approved. And in the United States, they only got approved around 5 or 6 years ago. So there's a wide spectrum of formulations that are available to us. And I will take you through most of them. So let's first talk about traditional testosterone esters, testosterone enanthate and cypionate, that have been in use for 7 or 8 decades. The dose which is used generally by practitioners is 200 milligrams every 2 weeks. Now, this is not a physiologic dose. This is a dose of convenience because you only want to inject the patient twice a month because intramuscular injections are painful. The most physiologic dose is to give smaller amount, but more frequently. So 75 to 100 milligrams weekly. In our older hypogonadal men, we use 75 milligrams a week. In our younger men, 100 milligrams a week. And if you look at these data from Dr. Snyder and Lawrence, they very elegantly summarize pharmacokinetics of these various doses and dosing frequencies. The most physiologic dose, which you see on the top left, 100 milligrams a week, the levels are very homogeneous and stable. I would not ponder on this spike. This is meant for other calculations, but if you look at week to week, levels are fairly homogeneous and stable. If you look at 200 milligrams every 2 weeks, there are peaks and troughs. And although these peaks and troughs might be within the normal range of testosterone, it does result in fluctuation in mood, fluctuation in a person's libido. And that's why we don't think that this is physiologic, and giving it more frequently does result in very homogeneous levels. If you give a higher dose, but less frequently, such as 300 milligrams every 3 weeks or 400 milligrams every 4 weeks, the peaks and troughs are more erratic and wide. So it is important to appreciate what is the physiologic dose and how it should be given. In terms of monitoring on treatment serum testosterone concentrations, it is important to appreciate that on treatment levels should be checked midpoint between injections. So if you are giving 100 milligrams every week, it will be good to check the levels 3 or 4 days after the injection. If you still want to continue 200 milligrams every 2 weeks, then the levels should be checked a week after the shot. Advantages of this formulation: it is very inexpensive and patients can be trained how to self-administer, or their spouses can be trained how to administer intramuscular injections. Many of our patients who may not have insurance, out-of-pocket costs on a monthly basis comes to around $25 to $35. So it's affordable even for those patients who may not have insurances. Disadvantage, of course, if you keep on using higher dose less frequently, then there are variable pharmacokinetics. There could be fluctuations in libido and in mood, and of course, there can be some pain at the injection site. Now, I mentioned ultra-long-acting testosterone undecanoate, which has been in use in Europe and Australia for 2 decades, and in the United States for about 5 years. It is available in many parts of the world at the dose of 1,000 milligrams that you give to start with. Then 4 weeks later, there's a loading dose, and then every 12 weeks. In the US, the dose that is approved is 750 milligrams, which basically is contained in 3 cc's of castor oil. In other parts of the world with 1,000 milligrams, it's 4 cc's. So it's a large amount compared to half a cc of testosterone enanthate and cypionate. So we give the first dose, and in 4 weeks, we give the loading dose. And then in the US, we give 750 milligrams every 10 weeks. In terms of monitoring T levels, we monitor trough levels and adjust the dose accordingly based on these levels. And these injections are given in the gluteal region. Enanthate and cypionate, because of the small volume, you can even give in the quads, in the thigh. But here we usually use the gluteal site. If you look at pharmacokinetics, and I would like you to focus on the bottom graph, serum total testosterone concentrations. After you inject, they do peak, but then they slowly decline over the course of the next weeks and months. This x-axis is basically every 2 weeks of TU treatment. So if you can spread it out, you will see that there is no significant peak and trough. It is just more of a plateau compared to the short-acting esters. In terms of advantages, less fluctuation. But again, if you give enanthate and cypionate every week, there are no fluctuations there either. Potentially less mood swings, and only 5 injections a year. And that is something which is much attractive to our younger hypogonadal men who only want to inject themselves every 10 to 12 weeks. In terms of disadvantages, there is one side effect, which is extremely rare, but has been seen in the initial studies especially, is what we call POEM, or pulmonary oil microembolism. And this is manifested as non-productive cough, which is very short-lived. And the thinking is that when the drug was being tested in clinical trials, rapid injection of this 4 cc, because it was being done in Europe, might have resulted in the drug getting direct access into the vasculature. And these oil bubbles, when they transit through pulmonary capillaries, it triggers a cough, some irritation. There have been a couple of cases of anaphylaxis, and those patients have been resuscitated. But the guidelines here from the US FDA has been that these injections should be given by trained personnel, either doctors or nurses or nurse practitioners or physician assistants. This is not something patients take at home, at least in the United States. We have to inject it slowly over 90 seconds, so a minute and a half. And then we observe the patients in the clinic for about half an hour before discharging them home. It is being used commonly in the United States, but of course, more so in other parts of the world. Now, intramuscular injections are considered painful by quite a few patients. When I was a resident, some of my mentors were using these testosterone esters, enanthate and cypionate, subcutaneously. And the pharmacokinetics that one sees with subcutaneous testosterone administration are more or less similar to intramuscular testosterone administration of these esters. But there was a side effect, a mild side effect, what it was called sterile abscesses, collection of fluid under the skin where you inject these drugs. And that resulted in sort of abandoning this practice of subcu testosterone administration. But it seems it has surfaced again. And recently, FDA had approved a subcutaneous auto-injector. This is the device, just like an insulin pen, and it comes in 3 doses, 50 milligrams, 75, and 100 milligrams of testosterone enanthate. And you simply click the button, the dose goes under the skin and then slowly gets absorbed into the circulation. And if you look at the pharmacokinetics of testosterone and testosterone's metabolites, DHT and estradiol, at various doses, it is a very homogeneous levels that you see, just like when you give weekly intramuscular injections. But this formulation, this autoinjector is expensive. And to circumvent this expense, I usually recommend to my patients who like injections but do not like intramuscular administration, is that you can give the same injection after drawing testosterone into the syringe subcutaneously. You don't need an autoinjector. And these data have come from Dan Spratt's group and Dr. David Handelsman from Australia. Although it was in female to male transgender patients, but they used testosterone cypionate, drew up testosterone in the syringe from the vial. Weekly injections were given, 1 ml syringe was used, and the needle was 25 gauge, 5/8 of an inch. And it was injected by the patients 2 to 6 inches lateral to the umbilicus or either in the subcutaneous tissue of the thigh. And if you look at the levels of total and free testosterone, that was pretty much stable throughout the course of the week. There were issues in terms of nodule formation of sterile abscesses, which resolved after a few days. There was localized cellulitis and urticaria in a few circumstances. So this is an option which is available to your patients. Transdermal patch is available, and it is available in 2 doses, 4 milligram and 2 milligram. 4 milligram is the starting dose, and it is applied to the upper arm, back, or thigh. When you are treating your patients with a patch, they usually apply patch at night around 10 or 11 o'clock. And it is good to measure testosterone levels 3 to 12 hours post-application. That gives you the best gauge of what the circulating levels are. It is convenient and mimics circadian rhythm because if you apply the patch at night, the peak levels occur in the morning hours and then dwindle. The next night, you take the old patch off, take a shower, dry your skin, and put the new system on. The main problem with this modality is the skin irritation, which occurs in as much as 2/3 of the patients. Skin irritation can be very mild, mimicking contact dermatitis, or a blister-like reaction. And a simple thing that you can do is ask your patients to apply 0.1% triamcinolone, any steroid cream, on that location where they plan to apply the patch, and that cuts down these allergic reactions significantly. So this is a very good modality which is available, and skin irritation can be cut significantly with topical glucocorticoids. Now, gels, of course, various formulations are available in the United States, in Europe, and in the Gulf. I won't go into specifics of each and every gel, but they are mentioned here. They are applied daily to non-genital skin. I usually ask my patients to wake up in the morning, take a shower to get it out of the way, dry your skin, and then apply gel to these areas which you see in the cartoon. In terms of monitoring testosterone levels, a week after gel application, you can check testosterone levels at any time. We prefer still close to the application of the gel that morning. So within 3 to 4 hours of the application, they come to the clinic or they go to the lab to get the labs done so that we can decide whether the current dose is adequate or the dose needs to be adjusted. It has good skin tolerance compared to patch. Things to watch for is potential for transfer to the spouse or to the kids. There have been cases of precocious pseudopuberty in men who have lifted their kids after applying the gel and they have not worn shirt because the residue can be there for some time. And that's the reason we recommend that sex, shower, and swimming should be avoided for the first 4 to 5 hours. But even later on, there might be some residue on the skin. So when you are dealing with kids, it is important to wear a cloth, a shirt, or a t-shirt, then there's no problem in lifting those kids. But otherwise, there is a chance of transmission. Same thing with the spouse. After 4 to 5 hours, there's a minimal residue there. You can wash it off, and then one can engage in sexual activity if need be. And lastly, I will talk about the pellets. This is something that our urology colleagues do a lot. We do not do in our clinic. And if our patients would like pellets, after confirming the diagnosis of male hypogonadism, we refer them to urology. Pellets are administered either in the lateral abdominal region or lateral thigh region. It is a surgical procedure, though minor. After cleaning the site and applying anesthetic, you take a trocar with stylet, and there are various pellets of different dosages, 80 milligram, 100 milligram, and based on how much you are putting in, you choose the site. As you can see here, after the stylet has been withdrawn, the pellets are lined up very nicely in the subcutaneous tissue. And slowly, by surface absorption, testosterone is released into the circulation. Side effects, of course, includes potential of infection, as with any surgical procedure. And although this track, which you see, should obliterate, sometimes the track remains patent, especially in men who might be obese because of increased intra-abdominal pressure. And there have been extrusions of these pellets in some circumstances. And this diagram below, or this picture below, shows you the size of the unimplanted pellet before they are implanted, and those pellets which were either removed for one reason or the other or spontaneously extruded. And as you can see, more days they have been within the abdominal, within the subcutaneous tissue, more thinner they are because of surface resorption of testosterone. So after discussing these formulations, I will talk about some of the benefits of testosterone therapy. And my job has become very easy because of the excellent overview that Dr. Quinton gave in his talk. What I'm going to do is touch upon some major areas. Here you see various proposed benefits of testosterone therapy: sexual function, masculinization, improving body composition, improving bone density. Now, these areas I have marked in green because in men who have organic hypogonadism due to Klinefelter syndrome, Kallman syndrome, or any acquired condition such as central hypogonadism post-hypophysectomy, hemochromatosis, chemotherapy-related testicular damage, there is no question that when your testosterone is that low, all these elements are achieved by testosterone therapy. That's what we mean organic hypogonadism. That's what needs to be treated. Now, there is a phenomenon of age-related decline in testosterone. And as mentioned by Dr. Quinton, majority of this age-related decline is mild. Sometimes it could be significant, very small percentage. But the benefits of testosterone therapy in this age-related mild decline have not been shown conclusively. And those are the areas that I have put in gray. Though testosterone improves muscle mass, even in older individuals, it has not translated universally in improvement in physical function. Similarly, there are no concrete data that testosterone improves memory or cognition, depression, and even the quality of life improvement is conflicting. Some studies showing improvement, some showing no major change. So what I'm going to do, since the crowd the audience is very much familiar with the concept that organic hypogonadism must be treated, I'm going to show some data in men with age-related decline in testosterone. And this is from the T trial or testosterone trial, which was conducted in 800 men aged 65 and older who had average testosterone after 2 draws less than 275 nanograms per deciliter. And this was an age-related decline. Men with organic hypogonadism were excluded. And the 3 main studies that I'm going to talk about is a sexual function study, vitality study or energy study, and physical function study. What T trials showed that in men who were randomized to testosterone compared to placebo did experience improvement in overall sexual activity. So this was a positive response. And this overall sexual activity included a lot of things. It included not only the act of sexual intercourse, but also included sexual thoughts, masturbatory activities, and so forth. So overall, it was positive in terms of sexual activity. When you dissect out and looked at the other outcomes related to sexual function, libido also improved in these men who were randomized to testosterone compared to placebo. And to our surprise, even erections improved in these older men who were given testosterone compared to placebo. And the reason I say surprise, because ED in general is multifactorial. It is the changes in the blood supply, the nerve innervation that may result in inability to either attain or maintain erections during sexual activity. But erections did improve, at least statistically. And if you look at this delta change in this questionnaire, which is called IIEF, or International Index of Erectile Function, it improved significantly in the testosterone group. But if you look at PDE5 inhibitors and look at the delta change that we see with PDE5, that is much more robust than testosterone. PDE5 inhibitors improve this score or erectile score by 6 or 7 points rather than 3.5 points. So although PDE5 are more potent, in this study, testosterone did improve erectile function as well. But there was no change in the walking ability in these men age 65 and older. The primary outcome of the physical function sub-study was increase in walking distance of greater than 50 meters during a 6-minute walk test. And as you can see, there was no statistical difference in terms of the ability to walk more in men who got testosterone compared to placebo. Similarly, vitality did not improve significantly. We had always assumed that testosterone improves vitality, but that was not the case. There was some change in both groups, most likely a trial effect, but then the curves did not diverge significantly. Now, in terms of bone density, there was a bone sub-study which did show that men who got testosterone compared to placebo had improvement in bone density of the lumbar spine and to some extent total hip as well. But again, these increments are much less than bisphosphonates and other bone-specific agents that have shown proven anti-fracture efficacy. The problem with testosterone is that we do not have fracture data. And that's the reason Endocrine Society guidelines for male osteoporosis suggest that if you have a man who is at a high risk for fracture, either osteoporotic or has encountered fracture already, and happens to have low testosterone and low testosterone-related symptoms, you may wish to give testosterone to treat those symptoms, but they must be treated with a drug with proven anti-fracture efficacy, just because of the fact that we don't have any data on fractures with testosterone. Now, the last part of my talk, of course, after talking about formulations and after talking about benefits, we must consider potential adverse effects of testosterone therapy. And the audience is very much familiar with many of them: male pattern balding, oily skin, suppressed spermatogenesis. If you are using injections with very high dose, testosterone is aromatized to estradiol, and you may experience gynecomastia. Some data that testosterone might worsen existing sleep apnea, but if you are treated with CPAP or dental device, then testosterone can be safely given to patients with the diagnosis of sleep apnea. But I'm going to focus my attention on these three elements: first, erythrocytosis, then prostate, and lastly, cardiovascular. And I'm sure that there will be questions from the audience during the Q&A session about these as well. So when we talk about testosterone and erythrocytosis, when you look at data from clinical trials of testosterone versus placebo, there is no side effect which is more commonly seen in men who are randomized to testosterone than polycythemia. And as highlighted by Dr. Quinton as well, that testosterone promotes erythropoiesis, and before erythropoietin became available, androgens were used for treatment of various refractory anemias. So it is logical to assume that testosterone may result in significant elevation in hemoglobin and hematocrit in some circumstances. These are data from Adrian Dobbs from Johns Hopkins, who had looked at hypogonadal men who were either treated with transdermal testosterone or intramuscular testosterone. And she looked at the hematocrit in both groups. And as you can see, more men who got intramuscular injections had elevated hematocrit compared to transdermal. Now, the dose here was 200 milligrams every 2 weeks, which, as you recall, is the dose of convenience, not the physiologic dose. And the high peaks that you get result in erythrocytosis. If you give 100 milligrams weekly or 70 milligrams weekly, you can cut down incidence of polycythemia significantly. So I think that's the message here, that it's not that the injections lead to more. It depends how you administer injections. If you give low dose more frequently, you can cut down erythrocytosis significantly. So what do Endo Society guidelines suggest? And other guidelines also direct practitioners to make sure that they take care of their patients the appropriate way. So any guidelines that you follow would be appropriate. But Endocrine Society guidelines suggest that once you have started a patient on testosterone therapy, monitor hematocrit at 3 months and 6 months time point, and then annually. Older age is a risk factor for erythrocytosis because metabolic clearance rate of testosterone goes down. And of course, if you use injections at those high doses, then you can put a person at risk. If hematocrit exceeds 54%, then one should pause treatment because there is some concern that viscosity of the blood increases to quite an extent at this level, and one does not want to cause any harm. So it's good to pause, evaluate the patient for any hypoxic condition or underlying sleep apnea. And once hematocrit normalizes, you can reinitiate testosterone at a lower dose. Therapeutic phlebotomy is also available if need be. Now, in terms of prostate, I want to mention to the audience that there is no evidence, either from epidemiological studies or clinical trials, that testosterone leads to prostate cancer. There is hypothetical concern, theoretical concern, that if a person has a small focus of prostate cancer to start with, which was not evident to the doctor or to the patient, either on physical exam or labs such as PSA, could testosterone treatment aggravate it? And the answer, we do not know. This concern, as I mentioned, remains theoretical. But what we do see overall, if you look at men who are randomized to testosterone versus placebo in various clinical trials, you see overall higher prostate events, not necessarily prostate cancer. PSA jump, which is logical because you're a hypogonadal man, prostate is an androgen dependent tissue. When you give testosterone, PSA is bound to increase a little bit. So overall, these events of biopsies and PSA elevations, be mild, are seen more in the testosterone group compared to placebo. What the society suggests is that one should screen for PSA in men who are 55 to 69. Now, as you know, we are getting away from screening in older individuals with PSA. But if you are considering testosterone treatment, then one has to be a little bit more cautious. We already talked about the contraindications of testosterone treatment. Once you initiate testosterone in your patients, then PSA should be checked at month 3 and month 12, and then based on the guidelines that you follow. Now, if during treatment, PSA levels go more than 4 in an absolute sense, or the delta change is more than 1.4 nanograms per ml, this requires some evaluation. Does not mean that the patient has cancer. It simply means that something needs to be done to make sure that we are not missing anything in the prostate. And the reason this number 1.4 has been mentioned is because of previous studies that have been performed looking at what happens to PSA in people who are on testosterone treatment. Now, if you look at younger men and older men who are hypogonadal, once they get testosterone therapy, the delta change in young men is 0.3 nanograms per ml, and in older men around 0.45. So suffice it to say, irrespective of your age, the bump in PSA is less than half a nanogram per ml. On the other hand, if you look at natural variation in PSA and follow a group of patients who are not on any medications, just follow them serially with PSA measurements every 3 months or every 6 months, the 95th percent confidence interval at the upper end is around 1.4 nanograms per ml. So natural variation can give you this bump. And that's the reason Endocrine Society guidelines have established this cutoff, because if your PSA exceeds 1.4, then it cannot be explained by the traditional bump that you see, nor it can be explained by natural variation. And that's why if your delta is more than 1.4, some steps need to be taken by you. Now, the last part is cardiovascular disease, and I only have one slide to show you, and I know that there will be questions. When you look at summary of the meta-analyses that have been performed looking at various clinical trials of testosterone versus placebo, you see that there is no unanimity. Some studies have shown that testosterone leads to increased cardiovascular risk, while others have shown that testosterone is neutral. And there are some studies that even suggest that testosterone might be beneficial. We do not know whether testosterone results in increased cardiovascular events or not. And the reason we do not know is because no published study that exists have included or have established cardiovascular events as the primary outcome. We do these studies to look at sexual function, quality of life, muscle function, and we record side effects as they occur. But in order to look at cardiovascular events as the primary outcome, you need thousands of men and to follow them longitudinally for a long period of time. So what I would say is tell your patients, if they are truly, if testosterone therapy is truly indicated in them, to mention that we do not know whether it leads to increased cardiovascular events or not, because the studies that have exist are mixed. But if you are initiating treatment in them, you can reassure them that you are going to follow them diligently and also educate them on signs and symptoms of cardiovascular events, such as MI or DVT or PE, because the FDA has suggested that practitioners do inform patients about this, even though data are inconclusive. And in about 4 years, we will have data from Traverse study, which is looking at cardiovascular events as the primary outcome. Approximately 6,000 men, 3,000 randomized to each arm, testosterone and placebo, and treated for more than 5 years. So we will have some conclusive evidence whether testosterone is harmful to the heart or the vascular system or not. So to conclude, testosterone is a drug, it's a medication, and it is meant for treatment of organic male hypogonadism. There are many functional etiologies for low testosterone, as Dr. Quinton mentioned, and you direct focus to removing or treating those functional etiologies. But if there's organic damage to testes or hypothalamus and pituitary, then of course, those are the patients who should be treated. Choice of formulation should be based on patient preference, cost, availability, and formulation-specific properties. Benefits and risks of testosterone are a function of circulating testosterone, not modalities. As endocrinologists, we should be able to titrate any formulation to achieve physiological circulating levels. So that is important for the audience to appreciate. Testosterone replacement in older men results in modest benefits, and cardiovascular and prostate safety remains unclear. And one should continue to monitor patients for benefits and adverse effects of testosterone therapy. And I always leave the audience with this painting by Lucas Grenache called The Fountain of Youth, where you see feeble men and women coming and taking a dip in the pond and coming out young and rejuvenated, changing into elegant attire and then feasting. To the best of our knowledge, there was no testosterone in this pool. So testosterone is not a fountain of youth, is a drug and should be used in men who have organic hypogonadism. I want to thank again the organizers and Dr. Khalil for hosting me, and happy to take any questions.
Thank you very much, Dr. Shehzad. And I think we have to open the floor for questions. We have half an hour, and it looks like we have too many questions. So I'll try to get them one by one if I can. To start with, there's some question on the circadian rhythm, and I think it was mentioned there is a circadian rhythm for testosterone, highest in the morning and latest in the evening. And then but again, the question here is if someone is receiving exogenous testosterone, what effect it has on the level of testosterone and LH, FSH. Would that be picked up by the LH if we give exogenous? I can open it to maybe Professor Richard can maybe ask this question.
So if you have a man with central hypogonadism on testosterone, they may have an LH level that, well, they will have an LH level that's like low or low normal to begin with. And so on testosterone, you would expect that level probably to become undetectable. If you have a man with primary gonadal failure on testosterone, generally speaking, you may not, so the normalization of the LH level is not an intended therapeutic target, and nor is it specifically recommended that you measure it. But if you did measure it, you would probably find that you would achieve, you'd find a high normal or slightly high LH level. And that's because testosterone isn't the only hormone feeding back on the hypothalamic pituitary axis. There are other hormones such as inhibin B, insulin factor 3 that feed back. And those hormones, if you've got primary testicular failure, are low or absent, and you're not replacing them.
Okay. Now, what do you expect, like in people that are quite athletics, involved in marathon runners? What do you expect the effect of exercise would be on level of testosterone? Would that be mediated by leptin, losing the leptin effect, or is there any other explanation for this?
Well, certainly if you reduce your, every man has their own critical fat mass, and if the fat mass falls below a certain level, that's when the testosterone levels fall off a cliff. And the advantage of professional athletes is that they work with sports dietitians and sports physiologists, and they're having the testosterone levels measured all the time as part of the anti-doping process. And so their trainers can tell when they're being pushed too hard, and actually they need to back off. Obviously, that isn't available for an amateur athlete. The other issue, of course, is the extent to which use of exogenous androgens might be shutting the axis down. Now, so WADA, the World Anti-Doping Agency, has access to well, their surveillance technology is completely covert. We don't know what they can measure. But interesting, one of the things they do look very carefully at the blood, at the red cell count, hemoglobin, and hematocrit. And if they see that for an individual athlete in their kind of athlete's biological passport, if they see that begin to rise outside the normal track, then they're allowed to infer doping and disqualify an athlete even without actually proving it. So they don't actually have to prove that you've taken an illegal substance. They can just say, this physiological parameter of yours, it's rising out of normal. The only explanation for it is that you're doping, you're out.
So how do you prove it? How is there a way to prove that if someone present to your office?
No, not for us. Not for us. The closest thing we can get to it is if you see an SHBG level in single figures, you might see that in a very obese man with kind of insulin resistance and prediabetes, because insulin switches off SHBG production. But if you're seeing a muscular guy, not obese, with a very low SHBG level, there's only one explanation, that's anabolics.
Okay.
But that doesn't count as cast iron proof, but that's very, very, if you see the single figure SHBG level in nanomole per liter, you're thinking, in a slim fit guy, this guy's been using anabolics.
In the same setting, maybe there's a question actually addressed to you specifically is, what are your thoughts on low sperm count post-metabolic surgery and in some cases post-GLP-1 receptor agonist treatment? Wouldn't reversal of obesity-related hypogonadism improve sperm count? So basically the effect of obesity weight loss on sperm count.
We know that the kind of hormone axis recovers completely after bariatric surgery, but of course the sperm count will take longer, whatever the original insult, whether it was obesity or whether it was inappropriate use of androgens. And again, people don't suddenly go from being morbidly obese to being slim. Just being seriously overweight has all kinds of kind of like probably pro-oxidant properties that act to affect the sperm count. But certainly weight loss is always going to be good for your sperm count, one way or the other. But the sperm count will always lag the hormone response. So for instance, whereas we know that after abuse of androgens and anabolics, your hormone axis in most men is recovered by about a year. In fact, your sperm production may take more than 3 years to fully recover.
Well, in that case, would you resort to the use of gonadotropins like SCG and FSH?
Well, it depends. I would rather not in some, but I would say if you have access to assisted reproduction technology, if you're a man with oligospermia, the best validated treatment is ICSI.
Right. Okay. Now, just another question regarding testosterone. It seems that, could you just highlight again the importance of measuring total testosterone versus free testosterone? Like you mentioned, and then the methodology there. You mentioned that mass spectroscopy is basically not as good as radioimmunoassay or immunometric assays in males versus females. But again, where do you measure testosterone total versus free testosterone?
So first of all, I would say if you've got a very good immunoassay, then in the male range, don't feel embarrassed that you haven't got a tandem mass spec assay. So the best immunoassays slightly outperform the best tandem mass spec assays in the male range. If you've got tandem mass spec, great. If you haven't, don't worry. Total testosterone will do for most men. Where you need free testosterone is in those men whose SHBG levels are kind of high or low, high in the normal range or below or low in the normal range.
Right.
And in those men, the calculated free testosterone, however imperfect, gives you a better marker of androgenicity. But of course, my favorite marker of androgenicity is the hemoglobin. Right. So for me, the hemoglobin is the HbA1c of andrology.
Right, right. Last question, and I'll come back. Maybe you can share some question with Dr. Shehzad. For people working night shifts, when to measure testosterone level? Would that impact the level of testosterone that you take early in the morning? And do you have a way of getting around this issue?
Yes. So basically, this is assuming you're in consistent night shift mode. You need to be in night shift for more than a week to really adjust your biological rhythms. But essentially, it's on waking. So if you've been in night shift mode for more than a week, then you should measure the testosterone levels on waking.
Right.
Whenever that time of day is.
Okay. Question now for Professor Shehzad. Someone who had gynecomastia induced by androgen replacement, how would you address this issue?
It's a very good question, and it's a problem which is commonly encountered in those patients who are given intramuscular injections, especially the ones in which the physiological administration pattern is not followed. For example, 200 milligrams every 2 weeks or 300 milligrams every 3 weeks. The reason being there is increased aromatization of testosterone to estradiol that basically leads to induction of gynecomastia. In these patients, I think the way to address is to reduce the dose and give it in a physiologic way. That should result in disappearance of gynecomastia, though it may take some time. But I think as testosterone levels dwindle down into the physiologic range, estradiol will follow as well, and that will take away that stimulus that is provided to the mammary glands. If you use 100 milligrams a week, or if you use 75 milligrams a week, just like erythrocytosis, the incidence of gynecomastia also has gone down significantly. We do not see that any longer, even in these injectables, if you use a small dose, but more frequently.
And there's another question in the same setting. In patients with prostate cancer, given anti-androgen therapy, basically with gynecomastia that is induced, the treatment is could be local radiation or aromatase inhibitor. But if really there is the patient has decreased LV function, how do you address this issue?
Decrease LV, left ventricular function?
Ventricular function.
So I think it's a good question. We see patients a lot from Dana-Farber who are undergoing androgen deprivation therapy for prostate cancer, and gynecomastia is a common problem. The best treatment for these patients who have painful gynecomastia, because most of the time gynecomastia is mild and tolerable. But if you do have painful gynecomastia, the best treatment is tamoxifen. And 10 milligrams twice a day is extremely superior as compared to aromatase inhibitor as well. I think the reason being, these are patients whose testosterone levels are in the undetectable range. Their estradiol levels are also in undetectable range because, it comes from testosterone. So the reason these men experience gynecomastia is because estrone, which comes from the adrenal gland, a metabolite of androstenedione, that is still being produced. So there's a mismatch, or there is alteration of the ratio between estrogens and androgens. And I think the way to treat it is tamoxifen. And oncologic studies have shown that tamoxifen is superior to aromatase inhibitors. And I think it was a very astute question that many oncologists sometimes also use external radiation to obliterate the mammary glands, and that is also an option. But tamoxifen would work very well in that patient population.
Great. Thank you very much. Question. Can we give testosterone to improve libido without checking levels before and after treatment? So basically follow the patient symptoms.
Well, there's no question that libido is one avenue which is very closely associated with testosterone. Libido is a mood issue, and testosterone regulates that mood. On the other hand, ED is not very strongly associated with testosterone levels. But here, as the talks today suggested, that it is not necessarily only a matter of subjective ascertainment, which you should do in terms of benefits and risks, but you also need to make sure that the intervention that you have embarked on is resulting in physiologic levels. So I think that is extremely important because different patients respond differently. We talked about that in older men, metabolic clearance is different. So a 75 milligram dose for a 70-year-old might result in different on-treatment circulating levels than a 30-year-old. So monitoring testosterone levels along with monitoring for hemoglobin and hematocrit or PSA is something which is part and parcel. Once you have found that on your regimen, consistently a person is having on-treatment testosterone levels that are in the appropriate range, then you can space out checking testosterone. But initially, I think you should be more frequent, but then less so.
I think they were pushed to ask this question because you mentioned that study in elderly where the delta was improved as far as libido action is concerned, the erection, actually not the libido, the erection issue.
Indeed. Mm-hmm.
And that maybe you want to clarify that this is not really open for its use for that purpose alone.
Indeed. I think one must monitor levels as well. Yeah.
Right.
Mm-hmm.
Do you have any experience with nasal testosterone, such as Natesto?
Yes, and I think it's a very good question. And I was not sure whether Natesto was available in the Gulf region or not, because many formulations that I did not discuss, assuming that they may not be widely available. I have limited experience with Natesto, and patients also do not prefer it a lot because it's 3 times a day administration. It's a drug which comes in a metered pump, just like you have Flonase and other nasal devices. It's a metered delivery of 5.5 milligrams to each nostril. So you press in each nostril a total of 11 milligrams combined 3 times a day. And there are some peaks and troughs. But just because TID is not very convenient for many patients, it has not sunk in for many patients. But looking at the data that available and published, it seems that it is resulting in testosterone levels that are in the physiologic and in the desired range. So if this is what the patient desires and you are able to titrate it, that would be just fine. Mm-hmm.
Okay. Can we give testosterone along with sildenafil in some patients? How do you see is it a complementary effect, or how do you perceive it?
So another very good question. If we take a step back, I think the first thing that we need to answer is what the patient needs to start with. If a person is hypogonadal, clearly organic androgen deficiency, generally older men, once you administer testosterone to them, libido definitely improves because the mood improves. But as I had mentioned, erectile dysfunction can also be due to other factors, vascular factors, neurologic factors. So we do end up giving sildenafil to many of our older patients in whom just testosterone therapy does not result in restoration of erectile function. And you can use it safely. And in terms of the synergistic effect of testosterone and sildenafil, there are some studies that have suggested that using them together may have some synergy, but some other studies have not suggested that. So I would say use it for the purpose of treating the patient. Many patients who come in primarily because they have erectile dysfunction and problem in terms of performance anxiety can sometimes reflexly inhibit your libido. It becomes a vicious circle. If testosterone levels are okay in those individuals, then there's no need to raise testosterone more. And those men start with PDE5 inhibitors first. So it just depends what the patient is showing up for. But in terms of synergy, there is nothing conclusive that giving both together will definitely result in improved quality of erections.
Right. I have now a question, maybe to just give you some rest to Professor Richard. A 40 years old with azoospermia, normal LH, FSH, and normal testes by size-wise and ultrasound. How to diagnose obstructive and isolated sperm abnormality? I mean, how do you make differentiating? Is that the decrease in sperm count is due to obstruction rather than something really primary in the testicles?
Well, I mean, generally,
varicocele, like for instance.
Yeah. Well, generally speaking, it's the size of the testes that gives you the clue. If you got like a nice, fat, juicy, healthy feeling testis, and no sperm in the ejaculate, that's likely to be obstructive spermia. If you got a testis that's small and associated with particularly low testosterone levels and high LH, that's far more likely to be non-obstructive azoospermia. And so the future for that really is urological microtesie, so testicular microdissection. The controversy there, I'm straight out of my field, but so in the urology field, there's some controversy as to whether it's worth giving things like tamoxifen, clomiphene, HCG as pre-treatment prior to microtesie. It's never been subject to clinical trials, but it's in fairly widespread practice.
Okay. Maybe a question for both of you, if you don't mind. How about the use of testosterone in females as far as really improving sexual appetite and performance?
So, I mean, my experience is extremely limited, and that's mainly because I don't really have much of a practice in menopausal women. First thing to say is that there is no preparation that is currently designed for a woman. So in order to achieve levels that are not drastically high, you know, you'd have to be using the lowest possible pump of gel, and then fractionating that a bit like, you know, drug users cutting cocaine piles. The other thing to say is that I do wonder whether some of the effect that's been seen with testosterone treatment in menopausal women actually relates to it being pro-estrogen. So, I mean, Shehzad described beautifully the management of male hypogonadism, or the monitoring that you do. When it comes to female hypogonadism, what happens throughout the world is take this and get lost. In fact, many of the guidelines, in fact, the Endocrine Society guidelines for pituitary disease, absolutely shameful. They actually say that do not measure estradiol level in your female pituitary patients on HRT. Well, why the hell not? And so it's so in women, you know, it's like this Wild West. Women are being given random doses of, if they're lucky, they get 70 beta estradiol. If they're unlucky, they get the contraceptive pill, or they get horse estrogen. And the doses may be homeopathic, you know, designed for a postmenopausal hot flush rather than for a young woman. And so you can see they've got vaginal dryness, irritation. They get given a bit of testosterone, and actually, maybe it's the metabolism of that to estrogen that's actually doing them the good. So I would say before you go into testosterone in a hypogonadal woman, make sure you've got the estrogen dose right, and make sure you're achieving a decent estradiol level. Say sort of 300 to 600 picomole per liter. Shehzad will tell me what that is in old money. And then also give them a vaginal estrogen. So, so as all of you, as Ali says, know, if sex were ever painful for us men, it would end tomorrow. You know, and so vaginal estrogen to make sex more comfortable can do wonders for a woman's libido. So a lot of things to consider before we think about testosterone in women anyway.
Thank you.
Yeah. I would second what Richard just said. Actually, the diagnosis of low testosterone in women is not an entity which is recognized by many societies. And I think the other thing to appreciate as well, that when you look at the work from Sue Davis from Australia, when you look at a woman's testosterone level during lifetime, the majority of the decrease of circulating testosterone in a woman that takes place is between the age of 20 and 40. After menopause, in a woman who has intact ovaries, does not experience further decline in testosterone. So a climacteric ovary, though devoid of follicles and devoid of estrogen, it is not devoid of making testosterone. It is, women who have undergone oophorectomy, or women who have premature ovarian failure. Those are the women in whom testosterone producing Hylar cells and theca cells are gone. But even then, as Richard mentioned, there's no approved formulation that is available in many parts of the world that can treat women. And I think estrogenizing them and also trying to target local discomfort, as Richard mentioned, might improve quality of life in those women.
Okay. So many questions. I'm trying really to sort them out. There is one on testosterone therapy and cardiovascular effect. And actually, I might take an example of quite athletic woman that is actually on multiple hormonal replacement that used them for bodybuilding, small dose of testosterone, small dose of estrogen to maintain certain stamina. And she was found to have increased number, the LAD, coronary LAD was quite calcified. And the question she asked really, would testosterone has an effect on enhancing really atherosclerosis and coronary artery disease? So maybe you would like to comment on this.
Yeah, I think it's tough to comment on this particular patient. You mentioned, Dr. Khalil, that it's a lady, right, who is taking that. Yeah. So, since testosterone is not given to women, and the studies that are there usually assess sexual function, quality of life. So we do not know. We do know, and this is a completely different context, that men or women who have abused anabolic steroids for performance enhancing purposes, they have encountered quite a bit of cardiovascular side effects. Eastern European countries, especially before the fall of the Berlin Wall, I think there are a lot of data, although anecdotal, but a lot of athletes, both men and women, who have experienced cardiovascular side effect. But it's a different context. They train a lot, and sometimes cocktails of androgens are being used. In terms of men, as I mentioned, that we do not have clarity whether testosterone can result in cardiovascular events or not. I did not have time to include a couple of slides from the T trial, the testosterone trial, because in addition to bone and in addition to sexual function and cognition, there was also a cardiovascular sub-study. Only 140 out of these 800 men were eligible for that cardiovascular study. And in addition to looking at coronary calcium, they also did CT angiography. And it was found that there was a mild increase during that 1-year intervention in soft plaques in men who were in the testosterone group compared to placebo. Do not know what this means, but statistically and quantitatively, the plaques did increase. So again, until we have the findings of the Traverse trial that I mentioned published in a few years, all we can do is just educate our patients that this is something we do not know much about, but we will monitor you carefully, and they should be aware of the signs and symptoms of cardiovascular events.
If I can just come in there just slightly.
Please.
So,
Yeah.
So Shehzad and I said the Traverse study is the key study that will be out in a couple of years' time. But in the meantime, the testes IPD meta-analysis is in press, and we were both involved in it. And so we know what the answer is. We're just not allowed to tell you yet because we're embargoed. in a few weeks' time, look out for the testes study coming out in Lancet, Healthy Longevity. It sounds like something out of Star Trek, doesn't it? Live long and prosper. Coming out in a few weeks' time, and that will give some preliminary data pending the traverse as to the cardiovascular safety of testosterone in men. In women, transgender men, so natal women, do seem to be at higher cardiovascular risk. And I do wonder whether that's got to do with ramming a hematocrit of 50% into an organism that's meant to have a hematocrit of 40%. So there is, but I think that's a different situation to obviously testosterone in hypogonadal men.
So many questions. I'm really trying to find and time is running. There's one in those patients at teenage groups who have short stature and hypogonadism. Can we use testosterone, or the priority is that for growth hormone? Because I know I think what the reason why I asked the question is the question of priming sometimes with low testosterone level to induce puberty. But I think it all depends on the presentation and the cause of the short stature.
Yes, I mean, if you have growth hormone deficiency, then the treatment for that is growth hormone. If you have pubertal delay, either due to hypogonadism or to constitutional delay, then the treatment for that is testosterone. And as you administer testosterone, so you develop the growth spurt. We know from in the pediatric literature decades ago, height, for instance, in Turner syndrome was fetishized, so Turner girls were given like high doses of growth hormone. They still are, but really there was a fetish for delaying their estrogen treatment for as long as possible to try and maximize their linear growth. And the results we see as adult endocrinologists of this generation was like, poor uterine development, poor breast development, low bone density, all for the sake of half a centimeter, maybe extra growth. I would have no fear of treating an adolescent with short stature and hypogonadism with testosterone. You'll see if they get the growth spurt, and obviously in the very rare cases where they don't, that's where you think, well, could they have a chronopharyngoma? Could they have wider hypopituitarism?
Okay. Again, the same setting, we did discuss that in female with loss of libido, and what form and dose of testosterone would you advise? It can be for both of you, actually. Either one can answer this question.
The question is, go ahead, Richard. Mm-hmm.
So assume this is a hypogonadal. I assume this is a hypogonadal female.
I know it's not clear here. She has decreased libido around the perimenopausal, and she has, let's put it this way, she has some loss of libido. You women would like to use some form of testosterone. If they have to use it, which form would they use?
I'd say, first of all, it's a last resort. First of all, make sure they got decent estrogen levels with oral or transdermal estrogen, and make sure that that they're using a regular vaginal estrogen to make sex comfortable, right. And that'll take care of 90%.
Right. So
and there aren't many left. I mean, Shehzad, this is a bit outside our experience, but
no, I concur, and as Richard mentioned, I would not prescribe. And I think those mood fluctuations in the perimenopausal age group are so common, and they are not necessarily because of perhaps even hormonal changes. They are all the other changes that they experience. So it's more of a mood issue that kicks in. So I would hold tight and make sure they're estrogenized.
I think we're over the half an hour. Last question I'll put through is, any thought about the newly FDA-approved oral testosterone soft gel, that Jatenzo, its efficacy and how to monitor? Really, they're up to date on really all the forms.
It is. It is commendable because, you know, that was also, along with Netesto, one of the formulations that I did not include because I thought that may not have been available yet in the Gulf. You know, our experience with Jatenzo is limited. It's basically same testosterone undecanoate that has been available in Europe and Australia since 1970s, except that it is much more refined, and the fluctuations that you see with the old formulation of testosterone undecanoate, it is less so with Jatenzo. It's a twice-a-day administration. It has to be taken with food because absorption is via lymphatics. And you know, in the seminal studies that were conducted by the company and Dr. Swerdloff at UCLA and his group, it looked like that it resulted in good benefit for those men who had opted to be part of the trial. The downside always with oral androgen formulations is a reduction in HDL. And that is something which was also seen in this cohort. And the other surprising thing was that, or perhaps not surprising, because you can see it with any formulation, since testosterone causes salt and water retention, there was some increase in blood pressure, systolic blood pressure by 5 millimeters of mercury. So yes, so I think if this is something that your patients are keen on trying, it is FDA approved. It has been shown in a couple of studies that it works. So I think one should use it based on availability and patient's choice.
Thank
So
you. Yeah,
before we end, can I say one thing?
Yeah, please.
Shehzad mentioned the use of testosterone cyprinate or nanthalate as subcut injections. Can I give you a shout out for the first time that was published? It was about 1985. It was by a bunch of Omani endocrinologists, published in the Saudi Medical Journal. We should quote it more. Yeah, and also, as Richard mentioned, another publication from Saudi Arabia in late 1990s or early 2000, indeed also underscored the possibility of using subcutaneous testosterone. So I think it's good that Richard pointed out that the credit should go to the audience who are there now, because subcu testosterone has been sort of brought to surface by those studies. Yeah. Mm-hmm.
Thank you very much. Actually, we have to give you credit also for being with us tonight and for giving really 2 excellent lectures and for entertaining so many questions. I have to say there is probably close to 90 questions. And if you would like really to have a look at the questions, and maybe if you would like to answer some of them, will be great for the audience. But in any event, you answered really quite a lot of number of questions, and you entertain us all tonight. Thank you very much for the organizer. We appreciate taking the time for the attendees. If you can complete your feedback, and the feedback will be displayed on your screen when you log out from the session. So please complete it once for all, and you will get your CME credit certification probably 4 to 5 weeks after the tonight's session. Thank you very much, and I wish you all the best.